Before I start, show of hands, how many of you have record system in your hospital for RDN? Yeah. What about the simplicity spiral? Okay. So still, so as we see here, still very low penetration of this kind of technology to treat hypertension. And we were talking on the side here just to, we need to increase the awareness of having this advanced technology that will help our patients in the future. And as a result, we will, inshallah, reduce the bad consequences of uncontrolled hypertension. Now, before I jump into my presentation here, I agree with Dr. Mohammed Kurdi about HTN3 actually gave us a setback in the progress of renal denervation. However, the half-full part of that, it actually opened the eye for future advancement in the technology. So the problem with HTN3, one of the problems actually was the used catheter was really ineffective. And as a result, new technologies have evolved, and one of them was actually the Record Paradise system, which basically excluded that inefficient way of ablating the renal arteries. So I was given the task to cover the Paradise ultrasound renal denervation system. So basically, as we know, the renal arteries are heavily innervated from outside. And every time when we discuss renal denervation, we are really thinking about a really consistent and circumferential 360 degrees of denervation. So in this technology, we are using ultrasound as an ablation modality. And the treatment zone, as I said, is really consistent, really circumferential. So we are covering the whole nerve fibers in that segment that we are ablating. In the same time, without an actual direct contact of our transducer, there is a cooling system that protects the renal arteries from inside, from damaging the vessel from the ablation procedure. So this is just to show you that when we ablate thermal simulation, so you see that there is really a consistent, uniform ablation throughout the circuit. So 360 degrees, as I mentioned before, and it reaches to a depth of 6 millimeter, which is what we need actually to do an effective ablation. And that's the depth of the sympathetic nerve fibers in that region. And as you see here, this is just a cartoon just to show you that it only takes 7 seconds per ablation to deliver a reliable denervation into that segment. And basically, as I said, there is a cooling mechanism to protect the renal arteries from inside, and it only takes 7 seconds per ablation. So these are the advantages of this technology that we use. So in terms of the total time for ablation is actually less than 1 minute. That's the total time. Per cycle, we only deliver 7 seconds. It is recommended to do 2 to 3 sites in the main arteries. So we only ablate with this technology, we only ablate the main renal arteries. And in terms of the type of the ablation, as I said, it's a 360 degrees circumferential. So we are not missing any of those fibers going through that segment. And we target the main artery. So with this technology, we don't do the branches. So we only target the main renal arteries. And the depth of the ablation from this technology is around 6 millimeters, which is the required depth for the nerve fibers. And as I said, there is no tissue contact, and the active cooling system is just to protect the vessel from inside. And as a result, in all clinical trials, published data, there is no reported injury to the vascular bed where the ablation is happening. So I'm just going to go quickly over the procedure overview. Basically, 6 quick steps. So we do, and we need to identify the renal arteries by doing a non-selective injection in the abdominal aorta, just to identify the ostia of both renal arteries. And then we place the guiding catheter into each one of the renal arteries, and we pass our workhorse wire. And over that, we take the picture and then make the measurements. And based on the measurements, we will select the balloon size appropriate for that renal artery. And as I said, so usually because we are ablating in the main renal artery, usually the size does not change from the beginning to end. And then we inflate the balloon. We make sure that we have a complete apposition of our balloon by injecting during the inflation. And once we see that it's completely opposing the renal artery, then we start to sonicate. And as I said, it takes 7 seconds per ablation cycle. And it is recommended to do 2 to 3 per artery. So it goes anywhere between 4 up to 6 per patient. So this is a case that we did almost a month ago in our hospital. It's a 44-year-old male who was referred to us from outside facility because of resistant hypertension. His usual systolic blood pressure was above 180, and he was on these medications. So he was in maximum candesartan, amlodipine 10, indapamide, carvedilol 25 BID, and clonidine. Despite that, his blood pressure readings were in the 170, 180s. Our investigation was unremarkable, apart from having a mild concentric LVH, which happens with uncontrolled hypertension. But all secondary workup came back negative. So we decided to take him for renal denervation. So this is the first step. So what we did is a non-selective injection in the abdominal aorta to identify the ostia of both arteries. And then we started with the left renal artery, and we measured the size of that renal artery. And then we went with our balloon. As you see here, the balloon is inflated. And when we injected here, you can see that there is no flow beyond that balloon. And that means the balloon is well opposed, and then you can actually deliver the treatment. So actually we usually start distally, and then we did the proximal segment. And then after that, we switch to the right renal artery. Again, we inflate the balloon, make sure that it is well opposed, and then we deliver our denervation energy. And then we take a final picture, and that was, this was a trend. So during our procedure, we measure the blood pressure every 10 minutes during the procedure, and this is the trend of the blood pressure for this patient. So as you see here, that the time of admission, the night before, the patient blood pressure was ranging in the 180, 170, and then it significantly dropped at the time of the ablation. And then by the time of discharge, after 24 hours, the systolic blood pressure was actually around 120. And we continue to follow this patient, and the same behavior happened to the diastolic blood pressure. We continue to follow the patient in the clinic, and that's it. That's for my case.